Ready? Okay. I'm a genetic counselor at Monaco Medical Center, and I also work with the Program for Jewish Genetic Health. You can go to the next slide. The Program for Jewish Genetic Health is a program that's connected to both Yeshiva University and the Albert Einstein College of Medicine. So it's basically a program that provides a lot of affordable and accessible genetic testing, like carrier screening for Jewish genetic diseases. Also, we do a lot of community education, which is in part, as Dr. Bright said, that I do a lot of talks about genetics and genetic counseling, and we also serve as a resource for the community. We can go to the next slide. So, and can you all see? Everyone? Okay. So, these are some of the most recent and pertinent Time magazine covers about genetics. Most of you will remember the one in the middle, Dolly, the sheep, which was cloned in 1997. The one all the way on the bottom here is very recent, 2012. New genetic tests can point to risks, but not always a cure. And this one up here, Genetics, the future is now. New breakthroughs can cure diseases and save lives, but how much of nature should be engineered? That was from 1994. So something that when I was preparing for this talk, I was sort of reflecting on the fact that we've been asking a lot of the same questions for a long time, and there's been this promise of genetics for quite a long time, that it was going to change healthcare, it was going to change our lives, and we're asking very similar questions now that we were in 1994, and that promise for a lot of people, they haven't really seen it come to fruition. And what I want to do for the next half hour, 40 minutes, is really explain what is possible right now. There are a lot of new technologies, a lot of new applications that can help people's lives today, not just this promise of some point in the future genetics will change your life. And that's what I want to spend some time talking about. So you can go to the next slide. What we're going to do is I'm going to give a very brief history of the field of genetics, a very, very brief amount of the science, so I won't bore you too much with science, but just enough that you'll be able to understand what we're talking about. And then go through some of the different genetic specialties that exist right now, and 3 examples of applications that you could use right now in your own health or in your own medical care. And then talk a little bit about, very briefly, what's coming down the pipeline in terms of the future of genetics. So, the next slide. Okay, so here's our genetics timeline. I apologize if now the letters are a little bit too small for some of the people in the back. I'm going to highlight just a few of them. So we've known about, even though genetic testing is maybe a more recent phenomenon, we've known about genetics for a long time, going as far back as the days of the Talmud, so 200 CE. There are cases discussed of a woman who had 2 children who both died, 2 sons who died after having circumcisions because they bled, presumably hemophilia, and the 3rd son that she has should not have a circumcision, right? So even though we didn't have genetic testing, we knew that there was this sense at the time that there were diseases that could be inherited, and we can take practical steps to actually prevent people from dying from diseases. The thing which probably most people will remember from the last time they took anything related to genetics in school was Gregor Mendel, the Austrian monk who did the pea plants, and he mixed the tall plants and the short plants and the green plants and the yellow plants, and he learned a lot about inheritance patterns. So that was in the 1860s. Coming a little bit more towards the present, the word genetics didn't even exist until 1905. And then in the early 1900s, 1910s to 1930s, was when the eugenics movement was actually very popular. So the idea that we should forcibly sterilize people because they shouldn't be reproducing, and certain people were more genetically superior than others. And actually, it's interesting that the current field of genetics developed very much as in opposition to the field of eugenics. They wanted to be seen as very, very different. Everything in genetics nowadays involves informed consent, so people can't have genetic testing unless they have informed consent. They can't, we're not going out and saying, you should do X and you should do Y, specifically because of this history of eugenics. And then we identified DNA in the 1940s, and that double helix structure of DNA wasn't even identified until the 1950s. DNA sequencing, which is probably one of the most frequently used methods of genetic testing wasn't developed until the 1970s, and in 1984 is when DNA fingerprinting existed. That's basically the genetic tool they use for paternity testing and also for a lot of forensic science. And then Dolly, of course, was cloned. The first mammal to be cloned was in 1986, 1987. And then the human genome sequence was completed in 2000, 2001. So that's sort of when, this was like a huge undertaking and a huge accomplishment for the field of genetics, that now we know the sequence of all of our genes, but we don't necessarily know what they all mean. And that, I think, is going to be a theme that we talk about a little bit today. And the very last thing I have there is the $1,000 genome, and I actually don't have a year put on there because now we're in 2013. The cost to 2014. The cost to sequence someone's genome, so basically to read through every single gene in the body, costs somewhere between $5,000 and $12,000, depending on what lab you use to both sequence and interpret. And the $1,000 genome is basically this term that refers to the point in time where genetic testing will become so accessible that it will only cost around $1,000 to get all of this information. And we're not really there yet. But that's sort of a benchmark that some of you might have seen the term being used in newspaper articles or in the media, the $1,000 genome. And I think that we're probably going to get there pretty soon just because the technology is getting so much cheaper. But once we have that information, what we do with it is going to be a very different question. So you could go on to the next slide. Okay, so this brings me to my family history plug. I think what I showed from our last slide is that even though genetic testing is a fairly recent technology in the last 50 years or so, the idea about knowing information about your family and your family health history and having that impact your own medical care and what diseases you're at risk for, that is a very old idea. And family history is probably the best way that you could learn about your own medical risks right now without even doing a genetic test. It's probably even more accurate than most genetic tests that are out there. And most people don't know anything about their family histories. And I can say this because I ask people information about their family histories every single time I meet with patients. Every single patient I see, I take a family medical history and I say, so what, how old are your siblings? That one even how old your siblings are, that one takes a little bit for people to come up with. What did your grandparents die from? What did your aunt and uncles die from? How old were they? Right? People don't know this information, primarily because families don't talk about it. Sometimes you're not in touch with your family members. But this is probably one of the most valuable pieces of information you could find out. And in fact, in the early 2000s, the US Surgeon General came out with a family history tool called My Family Health Portrait. It looks like this when you go to this website here on the bottom. And it is actually a way to help you gather information about your own family history and record it. And they actually declared that Thanksgiving would be National Family Health History Day. I don't know if anyone knows about this, but every year around Thanksgiving, they send out an email and try to remind people this is the day where you are gathering with your family, ask them questions about their health. And keep that information because over time, family history is not a stagnant thing. Family history changes over time because people develop other medical issues. And family history is probably, especially for a lot of common diseases, so things like diabetes, high cholesterol, hypertension, cancer, and neurological diseases, these are often multifactorial, which means that they have both genetic and environmental factors that contribute to their development. So for a lot of these conditions, we don't even know the complete genetic cause yet, and having information about, if there's no diabetes in your family, and your, diet and exercise, et cetera, is within reason, then probably you have a lower chance of developing diabetes than someone who has a very strong family history of diabetes. So those are the sorts of things that family history becomes very important for. Your homework will be to go home and speak with your family members and find out this type of information and record it somewhere, because you might know this, but then your sister, brother, child, cousin does not know this information. Okay, you can go to the next slide. Okay, very briefly, some of the science. The next slide. Okay, so genes are the instructions that tell the body how to grow and develop properly. We have about 10 to 20,000 genes in the body, and they are inherited from our parents. We get half of our genetic material from our moms, the other half from our dads. Even though we now know the sequence, basically the the spelling of every single gene in the body. We don't know exactly what all of them do. We don't know how they interact with each other, so our genes do interact with other genes, and we don't know how they interact with the environment. And we do know that the environment actually also plays a role in how our genes are expressed. You can go to the next slide. There are a lot of different ways that genetic diseases can be inherited. I'm going to briefly go through what these inheritance patterns are. So recessive inheritance is the way that diseases like Tay-Sachs disease are inherited. A person can be a carrier of the disease, but they are perfectly healthy, unaffected, will never develop the disease in their lifetime. But if two people who are both carriers have kids together, there'd be a 25% chance of having a baby with the disease. Dominant inheritance means that someone who is a carrier actually has the disease itself, and there's a 50% chance to pass it on to each child. An X-linked disorder, so X-linked means that a woman would be a carrier and she would be healthy, but there'd be a 50% chance she could pass it on to a son. Mitochondrial inheritance also is inheritance that's passed on from women to children, but it's a little bit more, if a woman is a carrier of mitochondrial disease, she probably is having some sort of symptoms, and she passes it on to potentially all of her children. And then de novo is actually interesting. So a de novo genetic disease is basically something which is a genetic disease. It's caused by a genetic change or a mutation, but it was not inherited. It happened as a new mistake for that particular child. So the child could potentially pass it on, but no one else in the family is at risk to have a baby with the disease. And it's not something which we worry about in terms of the couple having another child with the disease. We can go to the next slide. Okay, so genetic testing is basically looking at our genes to find mistakes in our genes. So there are a lot of different types of mistakes that could be in the genes. I'm not going to go through all the different types of mistakes we could find. Mistakes are typically called mutations. So we would be looking for a mutation or a mistake that's causing the gene to not work properly. And as it is right now, aside from whole genome sequencing, which we'll talk about a little bit more at the end, there is no catch-all genetic test. It's not like, you know, you go to your doctor and you say, okay, I want the genetic test, and they'll just, you know, draw your blood and do all of the tests at once. The way that we do genetic testing is really by looking at doing a very thorough genetics evaluation. So we're looking at both personal medical history, we're looking at family history, and we're trying to figure out, well, what is the specific condition that we're worried about, and what's the best genetic test to do for that particular condition. It's not, we don't know enough right now to be able to just, you know, draw your blood and test for everything. So that's why it's always important that genetic testing is done with a trained medical provider who knows how to pick the right genetic test and knows how to interpret the results when they come back. You can go to the next slide. So now, interpreting the results. Interpreting results of genetic testing is complicated, and it's important to always interpret results in the context of the family history and the medical history. So just to give you a few examples of how this could be different. So positive results, for example, that would mean that we found a genetic change. They did a genetic test, we found a change or a mutation, and now that could be diagnostic, right? If we tested you because we think you, or your child or your relative, because we think that they have a particular genetic disease and we find a mutation, then that is diagnostic. It means you have the disease. Sometimes genetic testing is done because we're trying to see if you have a predisposition to something in the future. So then if we found out you had a genetic change, it doesn't mean you have a disease, but it means that you might develop it in the future. It could also be predictive, so pre-symptomatic. Sometimes if we test someone who's young for an adult onset condition, and they don't have any symptoms yet, but they will develop symptoms, so that would be a predictive genetic test. And then we have carrier screening, which will also be, you have a positive result, you're a carrier, but you're unaffected. So depending on the situation, right, not every genetic test is the same, and not every positive result means the same thing. A negative result is basically we didn't find anything. So that also, as you can imagine, might be complicated to interpret, because if you have a disease, but we didn't find anything with a genetic test, it doesn't mean you don't have the disease anymore, right? You still have it, it's just either we looked in the wrong place, we looked at the wrong gene, or our technology couldn't find it. And then there's two other categories of results. So there's uncertain results. This is called a variant of uncertain significance. That basically means that we found a genetic change, but we don't know what it means. And that's in part because we don't know enough. The more testing that's done, the less likely we are to get a variant of uncertain significance. But right now, especially in populations that are minorities, so African Americans, Hispanics, because less genetic testing was done in their communities, we know less about the sequence of their DNA, and therefore when we find a genetic change, it's more common for us to say, well, we can't tell if this is causing disease or if this is just a normal change, because we all have normal changes in our DNA. That's what makes each person different. So variants of uncertain significance are definitely one of the more frustrating results we can get back. And then the last result would be an incidental finding. So this would be that we did a genetic test, to see if you had a mutation in this cancer gene, and we figured out that the person you think is your father is not really your father. Non-paternity is definitely an incidental finding that happens more often than you think. Only because when we're doing genetic testing, people come in thinking, oh, I'm going to see if my child has cystic fibrosis, for example. But when we're doing the testing, we can actually learn more things about you and your DNA than you had anticipated. So that's also one of the reasons that informed consent is very important, because people who are having genetic testing done need to understand what we might be able to find out. And those are also very touchy and sensitive situations that we then have to figure out how to discuss with the families. Okay, we can go to the next slide. Okay, so a little bit on current applications, what we're doing right now. These are the three major specialties in genetics. So this is prenatal genetics, pediatric genetics, and cancer genetics. I'm going to go through each one, just so you have a sense of what is involved in these specialties. So prenatal genetics, this includes both prenatal and preconception genetics. Preconception, we think more about carrier screening. So just so you know, Ashkenazi Jews are unique in the fact that they get carrier screening done before a pregnancy or before marriage or before even engagement. That's something that actually people don't realize until people will say, but everyone gets carrier screening first. So most people who get carrier screening in the general population have it done during pregnancy. Most of the people that I meet with who are carriers of genetic diseases are currently pregnant. And then we have to figure out sort of how to test their partner, how to figure out if the baby's even at risk to have that particular disease. For Ashkenazi Jews, there's a panel of more than 18 genetic diseases that are more common in the Jewish population that we can screen for. There are conditions more common in the various Sephardi and Mizrahi populations, but testing is not as good yet. We are working on it. The reason the testing isn't as good is because traditionally there were more Ashkenazi Jews in the US, and they pushed really hard to get a lot of diseases added to these screening panels. Depending on what country you're from in Eastern Europe, it doesn't matter. We can test you for the same diseases. If you are from Iran or you are from Egypt, we need to test you for different diseases. So there are not yet panels that are out there to test as effectively, but it's definitely something that we are working on developing. There's something new, so it's called expanded carrier screening. This is testing that came out in the past, I would say, 2 years. And this is basically the ability to do a different sort of a paradigm for carrier screening. So basically, instead of testing you for Tay-Sachs disease because you're Ashkenazi Jewish, we can test you for, 100 diseases, some of which are common in Ashkenazi Jews and some of which are common in other populations, because the technology has gotten so much better that we can actually test you for a much larger panel and have it cost roughly the same amount of money. So there are obviously pros and cons to this type of testing. If we test you for the Finnish mutation for a particular disease, you're not really likely to carry it. But some people say, more is better. If we test you for more things, we can give you a better sense of what you're a carrier for, and if, you might have a child with that disease. Okay, so that's more preconception and also prenatal. The other types of tests that are involved in prenatal genetics is screening tests, so things like ultrasound tests and blood tests for genetic diseases like chromosome abnormalities, so things like Down syndrome. There are a lot of screening tests and ultrasounds done during pregnancy, some of which can come up with results that we might say, you know, your baby has a higher chance to have this genetic disease, or your baby has a higher chance to have Down syndrome, or abnormal ultrasounds that show, you know, your baby has a heart defect, and we should talk about whether there's a genetic etiology. So a lot of prenatal genetics is involved with that type of testing. There's also diagnostic testing, so things like a CVS or chorionic villus sampling and an amniocentesis. These are tests that some people might have heard of. These are ways of testing during a pregnancy to figure out if a baby has a chromosome abnormality or some other genetic disease. With this type of testing, we can really only test for things that we know we're looking for. So these are also not catch-all genetic tests. It's not like someone has an amniocentesis and then we know that, you know, the baby doesn't have a chromosome abnormality and therefore the baby doesn't have any genetic problem. Every pregnancy, every woman and couple has a 2 to 3% chance to have a baby with a birth defect. That's a risk that everyone has. So the type of testing that we do is very specific, right? We would test to see if a baby has a chromosome abnormality, for example, and then if, let's say, we knew that the pregnancy was at risk to have another genetic disease like cystic fibrosis, we could test specifically for cystic fibrosis. But even with all those normal results, that doesn't mean that everything is fine and the baby is not going to have any problem, because everyone has a risk to have a baby with some sort of a problem. There's also new testing here, so this is also within the last 2 years. There's something called non-invasive prenatal testing for people who have been looking into this. This is basically a blood test that can give us information about the baby's DNA, so a blood test on mom. This is technology that they've been really pushing for a while, meaning the development of it has been pushed for a while, because no one wants to have to do a diagnostic test like an amnio that puts a pregnancy at risk for miscarriage if they don't have to. So for people who want that information, right, this non-invasive prenatal screening is basically looking at DNA from the baby that's floating around in mom's blood. And at this point, it's still considered a screening test. It only looks at chromosome abnormalities and not other genetic diseases, but it's something which they're definitely pushing, and we'll talk a little bit more about that part in a little bit. There's one other technology which is important to mention as related to prenatal genetics. That's something called PGD, pre-implantation genetic diagnosis. So this is a technology which is available for couples who are at risk to have a baby with a genetic disease, and basically this enables the couple to go through IVF, so in vitro fertilization. They create embryos outside of the body, and we could switch to the next slide. They can actually test the embryos during the test the embryos before they implant them. So this is like really wild, and when people hear about this, they think like we're really in the future. We can actually remove one cell from an embryo, test it for a particular genetic disease. So again, not everything. This is not saying that, you know, this baby will now not have any problems ever, but test it for a particular genetic disease that the couple is at risk to have a child with, and then they only implant embryos that don't have the particular disease. So this is actually, it's not perfect, right? So for couples who go through PGD, they still recommend doing something like an amniocentesis during the pregnancy to confirm, but this is actually a very good option, especially for couples who don't want to have to be faced with the chance of having to terminate a pregnancy that's affected. You can go to the next slide. Okay, so pediatric genetics. Pediatric genetics was actually the first area of genetics that developed, and that's because initially it didn't involve genetic testing. Pediatric genetics was involved with evaluating children and adults who had disabilities, birth defects, children and adults who we think or thought had genetic diseases, and figuring out what is wrong, what caused all of their problems. And this is how genetics started, by seeing these kids and adults and describing what it was that was wrong with them, and then figuring out what caused it. There are a lot of different evaluations which are used now in order to do a pediatric genetics evaluation. Genetic testing is only one of them, so a physical exam is a very big part, looking for features that might be suggestive of certain genetic diseases. Blood tests, ultrasounds, x-rays, all of those things are involved in a genetics evaluation. Looking at a family history is involved. And the point of this is basically because if we can figure out what's going on, right, if we can put a name to it, first of all, for families who have a child with a genetic disease, having that name is actually very important. So being able to say, this is what my child has, and it's not just some very random, constellation of problems, that can be very helpful for a family. it can be helpful because we can tell a family what other things we should be doing, right? So this is a child who has seizures, but actually this is a child who has other medical issues, and we don't know to look for them yet. But if we know what genetic disease they have, we can say, well, your child should also see a cardiologist, because we know that kids with this genetic disease can have heart problems. And we know that kids who have this genetic disease might benefit from X, Y, or Z treatment. So in that sense, being able to then direct medical management is very, very helpful. The other part of it is that if we know what genetic disease this child has and we know what caused it, we could tell you the chance that it'll happen again. So for a family who has a child with genetic disease to then say, you know, this genetic disease was de novo, right? This is unlikely to happen again. That, taking away that fear that every child they're going to have is going to have this disease is actually very empowering. Or we say, you know, this is a hereditary disease, we know what the genetic changes are, we can test for that in another pregnancy. Or we could even do PGD, and we can test for that even before a pregnancy while going through IVF, and then help that family ensure that they don't have another child with the genetic disease. I have up here Diagnostic Odyssey. Diagnostic Odyssey for those of you who can't see in the back. So one thing that is important to note is that not every child who has a genetic disease or who has developmental problems or medical issues, we can't diagnose all of them. We don't know what causes a lot. And you might feel like I'm saying this a lot, but we don't know a lot. For as much as we do know and as far as we've come, we really still don't know a lot. And for a lot of families who do have a child with various medical issues and developmental problems, they're going down this route and they're trying to find a diagnosis, but they don't always get there because we don't know. And that's just something that's important to keep in mind. Okay, you can go to the next slide. So the last of the major specialties of genetics is cancer genetics. So cancer genetics is basically dealing with individuals and families that have either a very strong personal or family history of cancer. So these would be people who've had multiple cancer diagnoses at young ages, families where there are a lot of people in the family who've all had either the same or similar cancers. So for example, breast and ovarian cancer run together in families, colon cancer and other GI cancers can run together in families. Basically, anytime that you think that there are too many people in the family who've had cancer, that's when I want you to call a genetic counselor. But in honesty, the idea is that we all have genes that are supposed to protect us from cancer. And for families where we see too much cancer, the concern is that there's actually something being passed down in the family, a mistake or a mutation in one of these genes that's causing people to have a higher chance to develop cancer. Cancer is caused by mutations for everyone. So genetic changes build up in our cells. And then our cells get to the point where they can't protect themselves from cancer the way they're supposed to, and they start growing and dividing out of control, and they develop into a cancer. So for people who have a mutation that they inherited, that process just starts a lot earlier because they started out with a mutation in all of their cells. There is genetic testing that's available for cancer, family histories of cancer. The recommendation would be, because I know that a lot of physicians will order some of these tests in their offices, and that's good because at the very least people are getting identified. I would always recommend that people meet with a genetic counselor so that they can go through a very thorough family history, because the thing is that people who are specialists in genetics know a lot more about what the tests are that are out there. So I'll get a lot of referrals of like, someone had a family history of colon cancer and they want us to do BRCA testing, which BRCA testing is associated with hereditary breast and ovarian cancer. So they sort of got it right partially because they knew that there was enough cancer in the family that they were worried there was something hereditary, but they didn't know enough to say what genes we should be looking at. And for hereditary colon cancers, there are many, many other genes that we would be looking at. So it's definitely something that, especially for because cancer is an adult onset condition, so sort of the prenatal genetics, doesn't apply to everyone, even the pediatric genetics doesn't apply to everyone. I think that cancer genetics applies to everyone because, as I said before, knowing about your family history and being able to sort of keep tabs on that can help really identify families. I mean, the idea is that if, let's say, we found a genetic change for someone and they haven't had cancer yet, so now we have a person who we can try to keep healthy by either helping them take preventive steps to reduce their cancer risk or by having them undergo a more intensive screening regimen so that if they do develop cancer, we can treat it and catch it at a very early stage. For the people that we identify who don't have a genetic change, they might not actually be at a high risk for cancer, right? So then you have a person who's been living with this fear that they're going to get cancer their whole life because they have this strong family history, but in fact, they didn't inherit what's causing the cancer in their family, so they don't need to be worried. So that's why I think it's a very empowering part of genetics, in my mind at least, because we can do something about this. We can try to keep people healthy, or we can tell people that they're not at a high risk for cancer. Okay, so now just a few other places where genetics has intersected into other specialties. So neurogenetics would be dealing with hereditary neurological diseases, epilepsy, muscular dystrophies, things like that. Ophthalmic genetics would be hereditary diseases of the eye, so hereditary retinal diseases, hereditary corneal diseases. Cardiogenetics is actually a very interesting field, primarily because it also, in my mind, feels very empowering. There are hereditary cardiomyopathies, hereditary arrhythmias, and these are things that if we know that you have one of these genetic changes, we can also take steps to try and keep you healthy. And then public health genetics is actually very interesting. So this is surrounding mostly the newborn screening program. All babies who are born in the US are tested when they're born through a heel stick to see if they have one of anywhere from 30 to 50 genetic diseases, that if we knew the baby had it at birth, we could actually provide treatment to help keep that baby healthy. So that's actually something which most people don't know about because, as I said, you're supposed to get informed consent for genetic testing, but most people don't. They do that heel stick and they say, oh yeah, we did that thing for the baby. And you say, okay, everything's fine, good. They also do newborn hearing screening. So babies are also tested to see if they have deafness at birth. Some people might have heard of, they had to go back because they failed their newborn hearing screen, or they had to test the baby's hearing again. I mean, these are also things that nowadays we have the ability to, for kids who have hereditary forms of deafness, we can actually put in cochlear implants, right? We can do things that can help them hear, and we know that the earlier that happens, the more likely they are to be able to not have any impairment from having the hearing loss. You can go to the next slide. Okay, so a few practical examples. Okay, the first one I want to talk about is pharmacogenomics. So this basically is referring to the fact that we know, right, as I said before, we all have genetic changes. That's what makes each person different from one another. And some of these genetic changes, we've learned, affect how the body reacts to different medications. So the two examples that I brought here are codeine and warfarin. I figured that those were two that perhaps people have heard of before. Codeine is a pain medication. So for people who are, okay, here's the science part. This, CYP2D6, that's the name of a genetic change. For people who have that particular genetic change, they metabolize codeine poorly. Their body doesn't break it down well. Codeine itself, if you were to take it and your body didn't break it down, your body actually would not receive any benefit from taking codeine because in order for it to work, it actually needs to be broken down by enzymes in the body. If you have this genetic change, it's not being broken down well, and it's not working well, right? So people who have this genetic change shouldn't be given codeine for pain medicine, right? So this is like very cool. Warfarin, I think this stuff is fascinating. You should just know. Like this was like so exciting for me to be like looking up. Warfarin is an anticoagulant, so it stops your blood from clotting too much. There are actually two genetic changes for warfarin. One of them is CYP2C9, so people who have this genetic change are also poor metabolizers of warfarin, meaning they don't break down the drug properly. Now for warfarin, actually, it works right when you take it.
It says right here, the CYP.
Oh, that's great. So I'm going to have another slide just with that exact template. Warfarin, it works right when you take it, and when your body breaks it down, it actually stops it from working. So if your body isn't breaking down warfarin correctly, then you have a much longer acting medication, and your dosage probably needs to be lower than someone whose body's breaking it down well. The other genetic change is VKORC1, which that particular genetic change involves makes your body clot blood less quickly, so reduced coagulation. So these two together, knowing this information, is actually going to impact how your doctor would be giving you, or what dosage your doctor would give you of warfarin. You can go to the next slide. And as we saw, we have this pamphlet that was put out in 2008 by the American Medical Association and 2 other organizations, basically for primary care doctors to say, you need to be thinking about this pharmacogenomic testing when you're prescribing warfarin for your patients, because this can have a huge impact on what kind of dosage you're giving them. And the idea is really because we want to reduce the amount of events or bad things that happen when people are taking warfarin. Okay, we can go to the next slide.
And surgeries.
Sorry.
You could bleed in a
Exactly.
in a
Because
routine surgery.
in a routine surgery, you could bleed too much. And if we can dose you properly, then that's very good. Okay, so the second one is personalized cancer therapy. So this actually also is very interesting. For a long time, when someone had cancer, what they would basically do is look at the different features of the tumor itself to basically say, can we figure out what the best treatment for this particular person will be based on the features we see in the tumor. So now a newer thing that we've started doing, and I would say this is almost definitely not routine, is actually looking at all of the genes in the tumor itself. Because as I said before, cancer is caused by mutations, and if we knew what gene was not behaving properly, then maybe we could figure out what the best treatment would be for that particular cancer. Because even people who have the same cancer, right, so let's say pancreatic cancer. If you have 10 people who have pancreatic cancer, each of their cancers are probably being caused by a different gene that's not working properly. We can go to the next slide. So this is a really interesting story. This was back in 2012. There was a doctor over at the University of Washington, I apologize, there was a cancer researcher over at the University of Washington, and he was diagnosed with leukemia. And he was really not responding to any treatments, and his cancer research team, because we don't all have a cancer research team working with us, but his cancer research team said, you know what, this is like our opportunity, right? We have this colleague, we love him, he's really not doing well, let's sequence all of the genes in his leukemia. And let's sequence all of the genes in the rest of his body and figure out what's the gene that's not working properly, so we could see if we can actually give him a better chance. So they did all of the sequencing. They found one gene that was the cause of his leukemia that wasn't working the way it was supposed to, and as luck would have it, there was a medication that was out there that they thought would have a very good chance of helping his particular case of leukemia. That medication had only been approved for use in certain types of kidney cancers. They somehow got him to be able to take this medication. His cancer went into remission, and that happened, that whole story happened in July of 2011, the fall of 2011. By July of 2012, when this article was written, he was still in remission. So this is something that I really do think is probably going to be the future of where this is going in terms of personalized cancer treatments, and using genetic information to be able to really pinpoint, well, what went wrong here that this person developed cancer, and how can we fix that particular thing? Because we know, we don't know what causes cancer, we don't know how to, fix cancer, but if we can do a more specific job for each individual person, then that might actually be a more effective route to go. Okay, the last example that I have is direct-to-consumer genetic testing. So some of you might have seen some of these companies. This is a representative list, because I know some people can't read. This is a representative list and not an endorsement of any of the above companies. Direct-to-consumer testing, the concept is basically that instead of going to a medical provider, doctor, genetic counselor, geneticist to have your genetic testing done, you are going to be you are going to contact a company, right? They're going to be advertising to you through the internet, through TV commercials, however the case may be. You spit into a tube and you send it into them, and they then can, because inside, basically the spitting into a tube sounds funny, you get skin cells from the inside of your cheek that they can then look at your DNA and give you some sort of information. So just for those of you who can't see, the 4 companies I have here is 23andMe, Navigenics, which is actually no longer providing direct-to-consumer genetic testing, but they were one of the first ones that came out probably in 2008, 2007. Ancestry DNA, which is Ancestry.com, actually came out with a DNA service, so they do this testing and give you information about your ancestry. And Wisdom Panel, which is a British company that gives you dog ancestry genetics. You laugh, but this is actually a very big field. Believe it or not, people really want to know about the pedigree of their dog or the genetics of their dog. Okay, so 23andMe is actually interesting. This is probably the one that most of you have heard of recently because that's the one that's been putting out TV commercials. They actually had done, their product was, you spit into a tube for $99. You get this printout of information both about your ancestry and about your health. So they claim to be able to give you information about what medical traits you need to worry about, how sticky your earwax is, things like that. And they actually recently got a cease and desist letter from the FDA. I'm not sure if any of you have been following this in the news. The reason they got this cease and desist letter is that the FDA contacted them maybe in 2010 because they said that your tests need to be under FDA approval. You have to show us that what you're testing actually, your results are reliable and they're accurate, et cetera, and the 23andMe didn't really respond. So they sent them the cease and desist letter to basically say that the FDA is concerned that the results that they are giving to consumers are both confusing to consumers and of little usefulness, of little utility. So the way that this testing is done, and I'm going into a little bit more detail about this because I know that there had been a question that was already submitted about it. The way this testing is done is not whole genome sequencing, which is reading through every single one of your genes. Basically what they're doing is looking at genetic changes. These are called SNPs, SNP, or single nucleotide polymorphisms. They're basically the variations that we talked about, right? The genetic changes that everyone has. And some of them there have been studies done in the past basically looking to see if someone has this genetic change, what is their risk for heart disease? If someone has this genetic change, what is their risk for heart disease? And they do, I think, a few hundred of these single genetic changes, which all have a very small risk associated with them, right? So if you have genetic change A, then there's one study that says that your risk for heart disease is 0.1% increased above the general population. So these are, we would consider them small effect. There are large effect genes associated with heart disease, but they don't test for those. So one of the things that I personally don't feel comfortable with is that they're doing a lot of this testing and they're sort of giving you information, but it's not a complete picture. They're not looking at your family history information. And they're not doing it with a medical provider helping you understand what this means for you. So we hear stories of people coming, taking their 23andMe results and going to their doctor, and their doctor's kind of like, I don't know what to do with this. And in part because it is not necessarily actionable information. For a person, I think from the genetics community, what we're worried about is, right, you have a really strong history of heart disease. And, lots of people in your family died from heart disease. And you go, you get this test done, and you say, hey, look, this test told me that my risk for heart disease is low. And in fact, from the things that they tested for, your heart disease risk might have been low from that test, but they didn't test for the 20 other ones that have a really important or contribute a lot to your risk. And they didn't look at your family history, and they gave you this information without knowing who you were and without knowing the whole picture. And for that reason, I feel less comfortable with that testing. That being said, they're not allowed to do health testing right now because the FDA has sent them a cease and desist letter. If you go onto their website, they will say that for new customers, they are only allowed to give out ancestry information. But that's sort of a moving target because I don't know what's going to happen over the next few months and years. Okay, we can go to the next slide. Okay, so future prospects. You can go to the next slide. Yes, thank you. Okay, so just very briefly, I want to talk about a few things that are sort of coming down the road. Gene therapy is one of those things. I think this picture here about gene therapy was from the early 1990s as well. It's one of those things that we have been, this is the dream, right? We could take one of your genes that's not working, we can pull it out, we can fix it, and then we could put it back in. It sounds really, really great. And it could cure tons of diseases, but we can't quite figure out how to do it well yet. There are a few diseases that gene therapy is successful for. So there's hereditary immune deficiencies that gene therapy has been successful for. There's blood diseases that gene therapy has been successful for. And the newer area that they're trying to work on is hereditary eye diseases. So for blood diseases and hereditary immune diseases, the way that they do gene therapy is through bone marrow. So you might have heard of people having like bone marrow transplants. They would actually take someone's bone marrow. They would put the working gene in. So it's not like we take out a gene and we fix it and put it back. We would just put the working gene in and then give that person back their own bone marrow that now is fixed and can work the way it's supposed to, thus curing whatever particular disease they have. This is really a handful of diseases that this has been useful and effective in. The other area that's really sort of coming down the road very fast is whole genome sequencing. So I did mention this before. This is where we read through every single gene in the body. And one of the downsides of whole genome sequencing, even though it's getting much cheaper, is that the technology has moved a lot faster than the science nowadays. So we can read all your genes, but we really have no idea what they all mean together. But the place where this is really interesting is because people are trying to figure out how can we put this into medical practice, right? This idea of personalized medicine. We know that you have this particular genetic change and therefore we can, give you X, Y, or Z treatment, or, you should take X, Y, or Z vitamin, right? This idea of personalized medicine is really very attractive and something that people want to figure out, how do we do this? And how do we get it into the medical record, and which doctors are supposed to be interpreting it, and how do we interpret it? And so the idea of doing this for, let's say, a healthy adult, right? You go to your doctor, you get your whole genome sequenced, and then you have this printout, this roadmap of what doctors you should go to, and what medical issues we should be worried about down the road, right? We're not there yet, but this is definitely something that they are working very hard at getting to a point where we can be there. We talked about this cell-free DNA testing during a pregnancy, right? A woman is pregnant and we can, take a vial of mom's blood and look at the baby's DNA there. We can actually sequence that baby's DNA and look at their whole genome. There have been at least 2 reports of this happening in Europe. So they put out a scientific study more to say that we can and not to just interpret it because, as I said before, we can't interpret it yet. But this brings up a whole host of ethical questions, right? Now we're sequencing a baby's DNA before they're born. What are we going to find out? What will a family want to do with that information, right? So if we sequence the baby's DNA and find out that it has a genetic disease, maybe the family's not going to want to continue the pregnancy. Okay, they have that right. But if we sequence the baby's genome and we find out that it has brown hair instead of blonde hair, right? This is what Gattaca was, right? Everyone's worried that we're going to have all this genetic material, we're going to have all this information, and what are people going to do with it? How is society going to react to that? And then the last case is going to be for a newborn. So this is actually something that I've heard at scientific conferences, which is very interesting, right? If the idea is that we're going to have this whole genome sequence, we're going to read through all the genes, it's going to be able to help us in terms of medical care, it's going to be this great thing. Well, when is the best time to do that? Are we going to do that when someone's 20? Well, we could have had all this information that would have been helpful before. Are we going to do that when someone's 5? It has been proposed, and I know that there are people who are doing research into this right now, to sequence the DNA, the whole genome of a child, when they are born. And now we have the information. Technically, you only need to do the sequencing once. Your genetic code is not really changing. So once we have it, so we can go back to it. We can reanalyze it at different points in a person's life. At the first, this is the model that I heard, which makes the most sense to me at least. Baby's born, you sequence their genome, and then you only unlock the information that tells you things that will be useful in the first few years of childhood. Okay, and then, a few years go by, you used all that information, and now you unlock a new level of information, which will only be useful, for the next couple of years. Then they turn 21, and they have the opportunity to decide what amount of information they want. In general, we actually don't do genetic testing for children unless it's something that would impact their medical management. So people who come in and want to know if their 4-year-old is a carrier of Tay-Sachs disease, we're not really doing that testing because we think that minors have the right to decide whether they want testing and when they want testing, right? So for, let's say, this scenario where we're sequencing all the genes of a newborn, do you really want to know that your newborn is going to develop Alzheimer's disease at the age of 52? Is that fair to that child to know that? Maybe not. Some people will say yes. I've definitely had patients who've come in and said that they want to know. This is very interesting. I had someone who, he won a raffle. It was like a charity something, and the prize for winning this charity raffle was that he got to have his whole genome sequenced. So, right, this is very cool. And I was sitting with him and I was saying, okay, so what do you want to know? Because whenever you do this type of testing, you have the option of finding out things that potentially you won't want to know, right? What if we find out that you have an increased risk for cancer? Okay, well, yeah, I want to know that because I would, I want to be able to keep myself healthy. If I knew I had an increased risk for cancer, I would take steps to try and whatever that meant. Okay, what about if you were going to develop a severe neuromuscular disease? What about Alzheimer's disease, right? There are things that you can learn from your DNA, and there are some things that we do know. And he actually said he wanted to know everything, because even if he was going to end up developing some terrible, terrible, debilitating disease that he was going to die from, he wanted to know to prepare himself, and he wanted to be able to, take the steps to prepare for his family and all of those things. But not everyone wants to know. And it's reasonable to not want to know. And that's why, as I said before, I really advocate for informed consent with genetic testing, because when you're doing a genetic test, you could find out information that you didn't want to know, and you really need to know sort of what you're getting yourself into and how that information is going to be useful for you. And even something which may seem benign, like finding out you have an increased risk for cancer, right, for a 21-year-old, right, and that increased risk doesn't start until they're in their 30s, well, does that 21-year-old really want to know right now, right? So there are a lot of these questions. Let's go to the next slide.
How old was that person?
Sorry?
How old was the person that?
Oh, he was in his 40s or 50s. Yeah. Okay, so the last thing to really think about is, as I started bringing up, a lot of these ethical issues, right? Genetics is a really interesting field. It's a slightly complex field. It's a field that most people don't know a lot about. But it's also one that every time we think about new genetic tests and we think about these technologies, there are a lot of ethical things that come up that you sort of have to take them hand in hand. We can't, start doing this technology without knowing how we're going to deal with some of these issues. And just for an example, one of the things that most medical centers will not do is genetic testing for the purposes of sex selection or gender selection, right? So if a couple is coming in and they're pregnant and they say, we want to do an amnio because if it's a boy, we're not going to continue the pregnancy, right? So if they tell us that up front, most of the time people are going to say, thanks very much, you can go somewhere else, right? Because then you're stuck in a situation where you have a couple who's deciding to terminate a healthy pregnancy just because it's not the right gender. So these are things that we sort of try to anticipate, but obviously we can't. Some of those issues is things like designer babies. So that's one of the things that with technologies like PGD, pre-implantation genetic diagnosis, which is where they test the embryo first and then only implant the ones they want. So the big concern there is that people are going to be able to start creating the children they want, right? They're going to only want to have babies who have blonde hair and blue eyes and, all the other embryos they're not going to use. And then we have a very big problem in terms of a social issue, right? So the people who can afford this technology are the people who are richer, so they're going to have their babies who are totally healthy and don't have any diseases, and then the people who can't afford the technology, so maybe the poorer parts of society, they're going to have kids who have all of these terrible diseases, right? This is not possible, right? The idea of designer babies, it's not possible. We do not have the technology right now to be able to do this, but it's one of those things that when we start talking about these technologies, people start getting worried and saying, well, how are we going to deal with these issues as they come up? You can go to the next slide. Okay, so this is actually one of the responses that the program that I work with has come up with. So in part, one of the issues is that people don't know enough. There's not enough education about genetics. There's not enough education about genetics for physicians, which the last time most physicians have taken a genetics course was in medical school. There's not enough education about genetics for the regular population. So what we did is we launched this online education series called Gene Sites, and the name will be changing in the next few months to myjewishgenetic.health.com. And it's basically a bunch of webinars and lessons that are online, which are designed for the public, and it's completely free, just to be able to keep people up to date on different areas of genetics. Go to the next slide.
Write that down.
And then what I'll leave you with, I'll read this for the people who cannot read it. So we have this representation of what's supposed to be, I guess, God, and a little angel there. And the angel says, God, the human genome has been unraveled. And God says, damn hackers, now I have to change the password. And the idea really being that the more we learn about genetics, the more we realize we don't know. I think that probably came across. But we keep on, we're not the same place where we were in 1994. We have newer technologies. We might have a lot of the similar questions and concerns in terms of the ethics, but we are progressing in our ability to provide technologies and things that will change healthcare, but we're not there yet. And the more we know, the more we know we don't know. So with that, I think I'll pause.